Hello, and thank you for joining us for the final general session presentation of Day 2 in the 2020 FOP Virtual Family Gathering. Just wanted to share a few quick helpful tips for attendees. If you haven't already identified the translation feature, please note that in the chat and question and answers panel on the bottom lower left of your screen, there is a tab called Wordly. So if you click on that, you will be able to open up translation for this presentation. And I also wanted to note that we'll have several presenters on video for the Q&A at the end of the session. So if you'd like to resize any of the panels, you can drag and enlarge your video or your chat to make it larger once we've moved to that Q&A portion of the presentation if you'd like. So I'm excited to introduce today's Complementary Therapies panel. This is a brand new panel for us to introduce at the Virtual Family Gathering. Today we'll be hearing from 3 different presenters, Dr. Michel Lemoine, Veronica Winkler, and Kelle Oestreich. We're going to be hearing first from Dr. Michel Lemoine from Paris, France, who collaborates with Dr. Genevieve Baujat to create the Tuttekin FOP Physiotherapy tutorial video for families in France. So unfortunately, Dr. Lemoine wasn't able to join us in person today, but he has pre-recorded his talk, which we'll be watching. And there are subtitles for English-speaking attendees. Dr. Lemoine is speaking in English, but he does have a very heavy French accent. So we put those there to help all of you. And after his presentation, we will be hearing the Tuttekin physiotherapy video. So.
Thanks for your confidence you offer us with accelerating attention to a French touch in medicine. So. Nice to present Dr. Baujat, clinician, and I had a Dr. specialist in physical medicine and rehabilitation. A few months ago, you perhaps discovered our tutorial movie, so on around FOP in French version. So FOP is a rare genetic disease, as we all know, characterized by a progressive ossification of muscles, tendons, ligaments, and article capsules. Well, physical therapy is one of the main gold standards in the treatment. It will differ by methods and goes along the age, the localizations of lesions and evolutions. So, physiotherapy, the next slide, usually physiotherapy is begun between 4 to 4 years old by of age when first rise occurs, especially around neck. While rate depends on the localizations of the lesion, the severity of the rises, and the goals aimed. So rate could spread between every day to twice a month. Twice a month. Physiotherapy could be completed with bariotherapy, which could be really useful, but not always necessary. Techniques and goals are precised by a medical prescription in France. I don't know if it's the same in America, no, but in France it's like that. Physiotherapists would have not to be shy and discuss with physicians on the other physiotherapists and paramedics more experimented in the pathology. At the beginning of the therapy, it's important that the patient and the therapist meet themselves as usual for long collaborative work and find positive empathy. First setup then. So the source therapy assessment, physiotherapists will be able by this way to set which functions are decreased, which impairments are perceived by the therapist and the patient, which could be different, which muscular function, which level of muscular function do the patient have about testing, stretching, and pain. Which movement and articles are impaired, which functions are impaired in distortion and deformities. Another important point is the chronology of the lesions and the pain which occur around the lesions. Well, physiotherapy will ever being useful all along the pathology, so it shouldn't be perceived as a project, on a long-term project. It should stay positive. Even sessions are built at home or in a medical structure, they would take place in pleasant room with a non-slippery floor. Physiotherapy should always stay smooth and comfortable based on active exercises around functional and analytic mobilities by short personalized sessions. Sessions should not be tiring and tiresome. It should never overtake unpainfulness, never forcing. These elements prohibit expressive mobilization, which could overtake limits without the advice of the patient and the alert of the patients. First thing is to keep the articles and muscles fullness without external restricting of the limbs or trunk. Goals and principles are variating among the ages. Physiotherapy goes among the age of the patient. Exercise should evolve with the age of the progress of illness. By young children, less than 4 years old, prevention of cervical ankylosis and anterior trunk function is one of the most important points. It should convey with gaming, inducting active movements, proprioception training, especially around balance and with the help of balneotherapy, which is very comfortable in childhood. With other children, walks are all around balance exercises about the objective of reduction injuries risk, posturation, the building of the body image and the bodily awareness. It will increase also the aspect of conscience of the environmental specifies on visual purview, eye tracking, oculometricity should be trained to help the children using every level of advice you can have all around him. So that's sometimes a large part of help with psychomotricity. So later on, with grown-up children, exercise will be all around balance and posturation, always in active, smooth stretching. It should also concern the respiratory control and ventilation, which could decrease hardly at around puberty. So muscular training should be always entertained classifications. In adults, in fact, it will be always around prevention and fight against distortions, respiratory functions, smooth active stretching, muscular training in unaffected areas, and comfortable messages. So, at Roselle, in fact, we find always smooth active stretching, guided or induced, learning of techniques of compensatory movements in physiotherapy. We should never forget that physiotherapy do not have to be painful. There are some special cases in particularity all among the evolutions. Modification and adaptation should be used during inflammatory rises because sometimes we should have to stop a few days the physiotherapy. At this moment, usually we usually need analgesic, anti-inflammatory drugs, and sometimes we can introduce some pharmacological research trials. When there's some rises, we can access all the work, the physiotherapy work about relaxation and respiratory. So we should take profit of this time to have some exercise around body image and body awareness, which would keep exercising in unaffected segments and localization. Sometimes it's useful to have some low-dose analgesic preventive treatment before the session. During this time, it's always important then to keep self-education to help the patient and his family to keep working at home between all the sessions. So that means shows the real important role of the family and integration, professional integration. Beside the physiotherapy, which was the main part of the therapy, we use in France to recover to occupational therapy. This kind of therapy has three major functions: the maintenance of precise manual and upper line function, positioning, and integration of technical system handlers about environmental control. So, for the precise manual function and upper line function, a lot of techniques are crossed with physiotherapy. Always we use smooth analytics active stretching, function application in movements of everyday life. By children, we used to try to use. Later, it will introduce computer works on organ for music, by example. About positioning, now with distortion that occurs while positioning in seat or bed is really important to define. Seats and mats should be comfortable and have to prevent increase of distortions with authorizing function and comfort. Helpful technical systems has an environmental control. Each of them should be defined with the patient and his family, including technology offers as electronic progress, request, hashtag preview, prices, social offers, on job. Later on, we have speech therapy. In occupational therapy, then we can use also domotic system, computerized system, and later professional adaptation with access to the society on the building where he works, where the patient works. So, aside, speech therapy could be useful around vocal command, articulation, pronunciation, swallowing, and later on at the end, computerized vocal command system sometimes, but only in severe cases. So, psychomotricity could be useful at several ages of illness. By young children, it was to help the patient to find peculiar balance, coordination and movement organization and tension of his body or image. Later, it will help patient to recover bodily awareness with his distortions and keep most of his functions. Psychotherapy is often useful because all along this psychotherapy could supporting could be important for the patient and his family. One of the most peculiar outline characters we can observe is an unusual humor sense in childhood with this patient. Sadly, around puberty, with the impairment created by the illness, it's turning dark, and then we have to find the right words to hope, fight, and stay as optimistic as possible, especially with clinical trials arising. What about doctors' function? What genetic question help us for their early diagnosis and therapeutic research trials with a high knowledge in tissue pathology? Medicine and meditation present should be seen as music conductor are used to for the prescription of orthotics as corsets, pain, orthosis. The role as a music conductor is to organize all the paramedics therapies to play together and help the patient. So they also decide the pharmacological therapy which could be useful a long time, especially analgesics, anti-inflammatory drugs like corticosteroids or colchicine, and the recover to pharmacological trials initially by geneticians usually. We could include respiratory systems prescription in collaboration with pulmonologists. For as conclusion, in fact, they know in France, as it's a rare disease, there's no real scientific data with randomized trial study, and the main part of this development is based on personal experience, analysis, and common sense. So, it's a multi-operational team of therapists and family as base of treatment, but the main importance is no pain, active smooth stretching, and keep the function as much as possible. So thank you.
La fibrodysplasie ossifiante progressive est une affection rare d'origine génétique.
Caractérisée par le fait que les muscles, ligaments et tendons s'ossifient progressivement.
Certains muscles ne sont jamais atteints, le diaphragme, les orbites ou le muscle cardiaque.
Chaque choc, chute, infection virale peuvent déclencher des poussées. Il s'agit d'une pathologie dont les conséquences sont différentes d'une personne à une autre et variables selon l'âge chez une même personne.
La kinésithérapie est un aspect important de la prise en charge thérapeutique des personnes porteuses de cette affection.
Elle aura différents objectifs selon l'âge et le stade d'évolution. Cette kiné doit être personnalisée et suivre quelques consignes dont est l'objet ce tuto. En général, la kiné est prescrite à partir de 2 à 4 ans lorsque les premières raideurs du cou apparaissent.
La fréquence des séances dépend de l'atteinte, des poussées et des objectifs requis.
On peut proposer chez certains 2 à 3 séances par mois et chez d'autres, au contraire, plusieurs séances par semaine.
Elle peut être complétée ou en partie réalisée en milieu aquatique, ce qu'on appelle la balnéothérapie.
Les consignes sont posées précisément par le médecin sur l'ordonnance. Le kiné ne doit pas hésiter à communiquer et à discuter avec d'autres kinés, avec des spécialistes paramédicaux, les rééducateurs, les ergothérapeutes ayant l'habitude de cette pathologie.
Avant de démarrer les séances, le kiné et le FOPeur feront connaissance, comme dans tout travail au long cours.
Le kinésithérapeute pourra ainsi connaître les segments ankylosés, les éventuelles déformations qu'il faut compenser.
Savoir quelles sont les ankyloses les plus anciennes et celles récemment apparues.
Bien sûr, savoir si la personne a des douleurs chroniques, des douleurs localisées ou provoquées, savoir comment est la marche, savoir s'il y a des problèmes d'équilibre.
Que la personne se déplace avec des cannes, en fauteuil roulant, où il faut continuer à entretenir toutes les articulations.
Le travail par kiné est à réaliser quel que soit l'état d'ankylose.
Le mot travail doit prendre une connotation sympathique et agréable, car on est dans du travail à long terme.
Et l'idéal est de travailler en positif. Que ce soit à domicile ou en cabinet, le lieu où se déroule la kiné est idéalement large, confortable, avec un sol non glissant.
Ouais, super. Abduction de hanche. On va donner des termes, ça fait classe. Et on relâche.
Il s'agit d'une kiné en douceur, par un travail actif, simple, en séance courte, personnalisée, pas de travail en série.
Les séances doivent être non fatigantes, il ne faut pas aller au-delà des amplitudes, ne jamais forcer.
Il faut surtout travailler à garder les amplitudes sans brutaliser de l'extérieur le segment de membre.
Est-ce que ça fait du bien, Nicolas?
Oui, ça me fait du bien, là.
Ça détend un peu?
Oui.
Il ne faut pas forcer, on y va tout en douceur et sans faire mal. C'est vraiment ça qui est important.
Le but, c'est de garder l'amplitude, mais surtout pas d'essayer de gagner. Ça, c'est pas possible.
Chez le jeune enfant, le travail visera à limiter la limitation du cou et la possible tendance à la flexion antérieure du tronc qui peut s'installer précocement.
Il pourra se dérouler à travers des activités ludiques et des exercices pour mobiliser le cou.
On voit que chez Alexandre, du fait de l'ossification, il y a une petite fermeture de l'angle inférieur droit. Et du coup, on va chercher à étirer. Alors, on écarte un petit peu les jambes. Voilà, on se met les genoux bien tendus. Et on vient se pencher pour venir toucher la main sans plier le genou. Voilà, c'est le haut du tronc. Bing, dong, ding, dong. Et hop, attention. Hop, impact. Au revoir. Bonjour. Tu vas bien, mon pote? Et là, tu le fais beaucoup mieux, du coup.
Dès très jeune, la proprioception est également à travailler régulièrement.
Il s'agit de la perception profonde des différentes parties du corps.
On cale bien les jambes, on regarde la balle. C'est un exercice qui est très important pour travailler d'une part la proprioception, l'équilibre sur les jambes, d'autre part la mobilité du cou, la mobilité des yeux, la mobilité de la tête, le regard latéral quand il va un peu sur le côté. Et évidemment, c'est motivant, on peut le faire en musique. 1, 2, 3, 4. Bravo! C'est excellent! Chez les patients FOP, où cette perception peut changer constamment à mesure que les enraidissements apparaissent, c'est tout ce travail autour des équilibres qui permet au corps de s'ajuster.
Je te déstabilise, Julia. Tu tiens l'équilibre et je pousse le ballon. Ok. On lève une jambe, je tiens le ballon, t'inquiète pas. Ferme les yeux. Et on relâche.
Chez les enfants plus grands, on s'attachera aussi à travailler l'équilibre avec deux choses.
Limiter d'abord le risque de chute en positionnant au mieux ses pieds.
Voilà. Les yeux ouverts. On ferme les yeux.
Apprendre à avoir conscience de l'environnement en maximisant le champ de vision par un travail sur la mobilité possible du cou et la mobilité des yeux.
Julia, je te mets les lunettes de star. Hop.
Oh, pas grand chose à travers tes lunettes de star.
Tu suis mon doigt, Julia. Donc là, le but, c'est de travailler la coordination oculo-cervicale. Tu suis. Viens par là. De l'autre côté. Hop.
Il est important, à partir de l'âge de la puberté, de travailler et d'entretenir les volumes respiratoires, de travailler le diaphragme et les échanges gazeux, c'est-à-dire inspirer, expirer au maximum pour évacuer le gaz carbonique et favoriser l'oxygénation.
Inspire à fond et souffle, allez, encore, souffle. Voilà.
On rappelle que le diaphragme n'est pas atteint, d'où l'importance de l'optimiser.
Allez, on souffle 2 fois, on inspire et le plus vite et le plus rapide possible. Allez, encore, on inspire, tu souffles. Très bien.
À l'âge de la puberté, souvent les enfants, on leur apprend à faire du bird, c'est un appareil pour développer les capacités respiratoires. Alors c'est pareil, il faut y aller tout doucement, il faut d'abord faut bien expliquer à l'enfant. Alors des fois ça peut être soit avec un masque, soit avec une petite pipette, quoi. Et puis il faut leur expliquer que tout ça c'est pour qu'ils puissent conserver une bonne capacité respiratoire.
Chez l'adulte, on ne pourra que redire l'importance du travail progressif de lutte contre les déformations du tronc, notamment du dos.
Si la personne peut encore, par exemple, s'incliner un peu sur le côté ou se pencher en avant, il faut encourager ces petits exercices, même s'il y a une toute petite amplitude, il faut quand même faire travailler cette petite amplitude.
Il existe un travail de mobilisation douce, des masses musculaires des membres inférieurs, des segments distaux.
En remontant vers les racines des membres, de la plante des pieds vers les mollets et les cuisses.
Cela permet de favoriser la décontraction musculaire et de favoriser le drainage veineux.
Voilà, c'est important d'aider le sang à remonter au cœur. Voilà, puis aussi de stimuler un peu les muscles du pied. On peut même associer un petit peu de mobilisation au massage pour intensifier le retour veineux. Voilà, très bien. Ça va?
Ça me détend une partie du pied et je sens que ça remonte un peu le long des jambes.
C'est vrai qu'il y a quelques mois, ta peau a été très fragile avec des ulcères et que là, maintenant, ça y est, enfin, c'est refermé. Donc, maintenant que c'est refermé, il faut vraiment stimuler ça pour pas que ça revienne, quoi.
Chez les grands enfants et les adultes, il faut aussi entretenir le bon état musculaire des régions non immobilisées, mais sous-utilisées s'il y a une ankylose sus- ou sous-jacente.
Par exemple, pour un blocage de la hanche avec un membre contralatéral non atteint, il faut garder un bon état musculaire de la partie basse de cette jambe. Un autre élément important, réalisé en kiné à tout âge, est l'apprentissage des attitudes et mouvements de compensation.
Par exemple, apprendre à descendre en chevalier serrant pour ramasser quelque chose au sol, ou prendre la pose de la petite sirène pour se relever.
Donc il s'agit pour le chevalier d'aller chercher l'objet à terre tout doucement. Plus il le fait doucement, plus l'exercice est difficile, et de se relever pour offrir cet objet à sa princesse préférée.
Donc, à partir d'une position de chute au sol ou autre, on va devoir lui apprendre à se dégager à partir d'une position dite de la petite sirène, où il va se redresser d'abord sur le côté, les deux jambes permettant de stabiliser, de pouvoir libérer un des membres si jamais il était gêné, tourner tout doucement vers le côté, se redresser, pouvoir passer en position quadrupédique éventuellement, suivant l'amplitude qu'il pourra avoir, et ensuite pouvoir passer à une position du chevalier servant et se redresser. Donc c'est une position de dégagement au sol.
La plupart des exercices que vous avez vus dans ce tuto font travailler plusieurs aspects à la fois.
Il est important d'adapter le travail du kiné pendant les poussées inflammatoires douloureuses.
Parfois, lorsque la poussée est très douloureuse, on peut ne pas faire de kinésithérapie pendant quelques jours.
Quand c'est douloureux, je ne force pas. Des fois, c'est repos. D'ailleurs, on ne voit pas la personne. Et puis, toujours rassurer en lui disant que bon, c'est peut-être un mauvais moment, mais ça va passer et puis ça va repartir.
Mais assez vite, il faut reprendre après prise d'antalgiques et d'anti-inflammatoires.
Le kiné peut faire pendant les poussées un travail de détente, de réassurance et de préservation de la mobilité dans la région atteinte.
Alors, on va commencer par lever un petit peu le bras, d'accord? On y va tout doucement. Voilà, très bien. Et on redescend.
Ah là, ce que tu m'as fait, ça fait trop du bien.
Ah, super. Ça détend les muscles un peu. Allez, on remonte le bras.
On insiste sur le fait que la séance de kiné ne doit pas renforcer la douleur. Dès que la période très inflammatoire diminue, après 2 à 8 jours selon la durée,
la kinésithérapie doit faire travailler les amplitudes articulaires doucement.
Par petits mouvements de rotation ou d'extension-flexion selon la localisation.
Si besoin, on peut proposer la prise d'antalgique en petite dose avant la séance.
Quel que soit l'état d'ankylose de la personne, il faut continuer, ça c'est très très important, il faut continuer à entretenir les amplitudes articulaires. Il faut toujours garder ce qui est là, quoi. C'est ça qui est important, ne jamais se décourager.
On écarte. On tient un petit peu. Et tu rapproches. Ok. On fait un peu les rotations. Alors.
Ouais.
On va tourner. Voilà, doucement le bras vers moi. Très bien. Et tu reviens. Vas-y, tourne. C'est bon là, ça va?
Oui, c'est bon.
Tu m'arrêtes hein, si ça fait mal. Hein.
Oui, mais je le dis.
Parce que c'est pas utile.
Il faut que la kiné soit conviviale et puis que le patient il reparte de sa séance un petit peu le cœur un peu réchauffé.
L'auto-éducation et le relais avec les parents est également très important.
Pensez à envisager avec les parents et ou le patient des exercices pour prolonger le travail à la maison.
Et pourquoi pas en s'amusant, en utilisant de la musique, des rythmes.
Pour siffler, chanter, danser.
Soyez sûrs, j'en suis fière, je vais courir dans le cathéter. D'être avec vous ce soir, j'ai le cœur qui pétille, Mimi serre-moi à boire, on a les yeux qui brillent. Papaya, paya, papa, paya, paya, papa, papaya, paya, papa, paya, paya, papa. Paya paya papa, paya paya papa, paya paya papa, paya paya papa.
If watching that video and that little girl singing doesn't bring a smile to your face, I don't know what does. And we are eternally grateful to Dr. Michel Lemoine for not only creating his presentation and recording it, but also transcribing it for us to make it as accessible as possible for our attendees, and to FOP France for making that wonderful video. I think that is really a kind of a hidden gem in the FOP community resources that we offer. So I'm so glad we could use this platform to share it with all of you. And thank you to Dr. Baujat, who's here to participate in our Q&A panel in place for Dr. Lemoine at the end of this session. So next we are going to be hearing from Veronica Winkler. So Veronica is a certified clinical competence speech-language pathologist who has worked in a variety of settings since beginning her career, including inpatient, outpatient, skilled nursing, home health, private practice, and some school-based settings. Veronica enjoys all areas encompassed within the wide scope of speech-language pathology, but shows special interest in and has pursued additional education in the areas of feeding therapy for infants, children, and adults, early speech and language development, voice therapy for adults, and cognitive therapy for those with dementia, traumatic brain injury, and strokes. So over to you, Veronica.
All right. Hello, everyone. As Hope said, my name is Veronica Winkler, and I have, in fact, worked with a variety of settings in my career so far. So I hope that I can give you a pretty well-rounded approach to how speech therapy can be beneficial to the FOP population. So within my presentation today, I'm just going to discuss some management options for some of the FOP symptoms as they relate to the scope of speech-language pathology. So a lot of people, when they hear speech therapy or speech pathology, it's kind of an interchangeable term, they typically think of somebody helping another person who has difficulty speaking, and that definitely is one aspect of our job, but we actually work with a wide variety of systems of the body. And so here I've just listed some of the different domains of speech therapy that can potentially be affected by FOP. So as I said, obviously the speech can be affected, hearing, language, swallowing, respiration, voice, and cognition. So these are all areas that any speech therapist or most speech therapists should be able to assist with. And I'll go into more detail within each domain up next. So let's start with speech or articulation. So that's basically how well you're able to say speech sounds and be understood when you say those speech sounds, and how that is impacted by FOP. Well, there can be ossification of the lingual or tongue muscles, and if that happens, you will likely have reduced tongue mobility, and that is a requirement to make clear articulatory contacts in the mouth. This may not be a huge issue depending on the degree of ossification of the muscles. It may result in just kind of some slurred speech, or just maybe it may take people longer to get different sounds out. They may still be able to make the contact, but that is something that basically can impair how well a person is understood, or their speaking intelligibility is what we refer to it as. Another way that your speech can be impacted by FOP is when there is temporomandibular ankylosis or jaw ankylosis, and this just results in a reduced mouth opening, which doesn't necessarily affect the articulation piece as much. It does affect the what I call the labial speech sounds, or the speech sounds you have to use your lips to produce. What the jaw ankylosis probably affects more is just how loud you can be. That's also affected by the respiratory system as well. But if the mouth is not able to open very wide, you're not going to be as loud, and that can also result in reduced speaking intelligibility. So given that information, well, what can you do about it? You can work with a speech therapist, and given the nature of FOP, the progressive nature of it, as a speech therapist, I would focus on more compensatory strategies to improve speaking intelligibility. So some of those can be rate reduction. Anytime you can slow your speech down to give those muscles more time to make that articulatory contact in the mouth, it's going to help you be more understandable. And then there's some pacing strategies that you can use. I won't get into a ton of detail with those, but basically it's all, the goal would be to slow your speech down and to give those muscles more time to do what they need to do. Now, I don't know how severe any of the patients that currently have FOP are experiencing the ossification of lingual muscles or the jaw ankylosis, but it may be more severe that the communicating with speech is becoming more and more difficult. And if that does become the case, or if that is the case, a speech therapist would definitely be of assistance in seeking out more alternative or augmentative communication. So I have listed alphabet board. That's something that could be used if somebody is still using speech, but they are very hard to understand, and even any rate reduction strategy has not helped. Sometimes using an alphabet board to augment their speech is all that's needed to make them more understandable. And then again, on the more severe side of things, there's different text-to-talk apps. You type in what you want to say and it says it for you, or again, just kind of augments what you're already saying, can give your listener clues as to what those words were that maybe didn't come out as clearly as possible. And then again, if speech is not possible at all, there's more high-tech apps out there. I'd say that's kind of where a lot of the AAC is moving, is to apps. There are more strictly AAC devices like a Go Talks and things like that. But I would say a lot of the people who are needing total substitution for their verbal are going to more apps like Prolo, Quotago, and there's a variety out there. You would want to talk to your local speech therapist about what would be the right option for you if that were the case. The next domain of speech therapy that is affected, or very likely affected by FOP is hearing. And hearing loss, it occurs in approximately 50% of patients with FOP. That's a pretty high percentage. So it's definitely something that you're going to want to be proactive about. And the onset is typically during childhood and can occur gradually. And it happens likely due to the ossification of the middle ear structures. However, some hearing loss is neurologic in nature, so that just means that the hearing loss is originating more in the brain or the nerve versus the outward structures of the middle ear. And because it's typically a result of the ossification of the middle ear structure, that means it's typically a conductive hearing loss, which is a good thing because those types of hearing loss typically respond well to external amplification, such as a hearing aid. So, regarding hearing loss, what should you do about it? Definitely regular hearing evaluations done by an audiologist are an essential piece to preventing any negative side effects of hearing loss with FOP. And I specify on my slide that it should be done by an audiologist because of the progressive nature of FOP and the progressive nature of the hearing loss itself, the changes to hearing may be more subtle than just what your school nurse might identify, or even the screenings that they do at the doctor's office. Those screenings are more of a pass-fail, and they don't really give you any information about where your hearing is actually at. So I definitely recommend all evaluations should be done by an audiologist because they will give you, an audiogram that has where your hearing is at exactly, so that you can track it as you continue to develop. And so I recommend, and I believe that the FOP treatment guidelines recommended once a year. From my perspective as a speech therapist, once a year I think is a minimum I mean, as long as the hearing is normal, I think that's okay to keep that pace. But if they are starting to detect any amount of hearing loss, I would recommend to increase that frequency to every 3 to 6 months, or if the evaluating audiologist has a different recommendation, of course, follow those recommendations. But from a speech perspective, I definitely recommend being proactive about identifying the hearing loss and tracking it, especially if the hearing loss is already showing up from ages 0 to 3, just because that is a crucial time for children to develop their speech and language. And if there is any amount of hearing loss present, you're going to need to be proactive about that to ensure that normal speech and language development occurs. And I say more frequent checks as when they are young, every 3 months, just because, you know, when the baby is a year old, 3 months is a significant portion of their life. So if you're waiting 6 months or a year to get their hearing checked again, that's a long time for when you compare it to the overall age of the child. And again, a lot of that speech and language development occurs in that 0 to 3 age range, and it's really something that can be, you know, if hearing loss occurs, and obviously it's very likely that it will, it doesn't mean that the child won't develop normal speech and language. Of course, it's just there are a lot of things that can be done in that age range, especially the 0 to 3, that can prevent any further delays in that area if it's acted upon timely. So I'm going to go into a little more detail about that. So what can you do? I think, especially at least I can speak for the United States, infant toddler speech and language services are free to everyone, every child 0 to age 3. And the way they do it in the United States, it's more of a coaching model. So therapists will work not just with the child, but they work a lot with the parents on ways to stimulate language and speech development in young children. And so, you know, if your child at their 1-year appointment has normal hearing, that's great. I still think it would be a good idea to enroll in these services knowing that your child may develop a hearing loss, and it would be great to have these tools and these skills kind of in your back pocket to just be encouraging that speech and language development in a little bit above average way, just to again be proactive so that if the hearing loss does occur in that 2-year-old, 3-year-old, 4, you know, any of those ages, that your child has a really strong base for speech and language, just because of the way you're interacting with them. So another thing that you can, this kind of goes along with what I already said, is to just be intentional about your language stimulation when you are with your child. It's easy, especially if you have multiple children in your household, I can attest to that too, to take the time to really sit down and play with your child, or play with them and talk to them while you are playing. But if I had a child with FOP, I would definitely make that my priority to make sure that I do regular book reading. And when I am doing a daily activity with them, whether that's getting their coat on, or getting them ready for bed, or changing their diaper, I am talking about what I am doing all of the time. I'm narrating my daily activities to them all of the time. So that's something that anybody can do, and you know, it's good for all children, regardless of FOP diagnosis or not. And then, of course, if the hearing loss is present, you should definitely ensure that your child is receiving speech therapy services, whether or not they are, you know, an infant, toddler, or school age. I'm not sure how common it is for hearing loss to occur later in in adulthood. I mean, besides the normal type of age-induced hearing loss. But either way, if you are experiencing hearing loss, I would definitely make sure you're working with a speech therapist on what the best strategies are for you to maintain or to prevent any delays in speech and language. And then, of course, if hearing loss is present and the audiologist that you are working with says that it is appropriate, the use of hearing aids is definitely going to be helpful just to make sure that you have the best possible signal getting to your brain that you can. Again, and that will help prevent any speech and language issues as well. So I don't know if I made this distinction before, but kind of in the beginning I was talking more about speech articulation, your body's ability to get the speech sounds out. Now I'm just kind of going to talk a little bit about the language component. So that's your ability to, sorry, I'll advance, your ability to understand the words that are spoken to you, your ability to have a good vocabulary, having the ability to put sentences together appropriately, so grammar, syntax, your ability to answer questions correctly. All of those things are part of your language system. And if there is a hearing loss present, that language system is at risk in terms of development. So what can you do about it? Well, basically following those other guidelines I had mentioned earlier about being proactive about managing hearing loss are the same to ensure that you are stimulating language development in your child. So make sure that you're doing regular hearing evaluations, providing intentional language stimulation in the home. Again, I would definitely try out the infant toddler speech and language services if you have a child of that age, and make sure you're getting fitted with appropriate amplification like hearing aids. And again, make sure that your child is receiving speech and language services if the hearing loss is present. And I actually have my own private practice that I run out of my house, and I have a Facebook page. So my practice is called Words and Herds, or Winkler Words and Herds, because I live on a farm. We have cows. And I've just been trying to add a lot of informational videos to my Facebook page for parents, and I do use these as a reference for some of my patients, but some things that I think might be beneficial, especially, again, if there's hearing loss present or if you're trying to prevent any speech and language delay as a more of a preventative measure or cautionary measure. I would definitely check out, there's Talking with Your Toddler videos that are just demonstrating how to incorporate language stimulation into daily activities with your toddler and even preschool age. I have some developmental norms for speech and language on there, and just some more specific sensory or hands-on activities that within those activities I kind of talk about how you can specifically target language within each activity. So I would definitely check out the Talking with Your Toddler videos. It's great. I found in my career that it's one thing to tell somebody what they should do to stimulate language, but what a lot of people need to see is just how you do it. And so definitely video demonstration has helped a lot of people in my local community on interacting with their young children. Another major area I would say to be proactive about is swallowing. So speech therapists work a lot with this area in the hospital setting and in the skilled nursing home setting. And how this could be impacted by FOP. Well, again, if there's ossification of the lingual muscles or the tongue muscles, this can impact safe mastication or chewing and then the transporting of those solids to the esophagus appropriately. But it's not only a solids issue, it can also be an issue with liquids, getting the liquids safely back to the esophagus. And of course, if there's any, I guess, deficit to the swallow, people may start eating less, and they may then start to lose weight, which is not something you want to see happen either. Again, the submandibular swelling that can occur with FOP also impacts the safe chewing and transport of solids and liquids. Also can definitely reduce a person's intake and result in weight loss, as does the jaw ankylosis. Impacts safe mastication and transport of solids and liquids. I guess the reason I'm so redundant with my slides is I just want to make the point that if there's any deficit going on with the swallow mechanism, it can result in issues with chewing and transporting and weight loss. And then at the bottom here I really want this to hit home as well. Anybody that has any of these symptoms is at an increased risk for aspiration. And in this population particularly, we definitely want to prevent that just because of the already compromised respiratory health of a lot of FOP patients. So I have on here just a little picture of the swallow mechanism. So you can kind of see the tongue is that big fat pink muscle. So what I'm hearing is that a lot of the ossification is happening at the base of the tongue. And then if there's submandibular swelling, again, that's going to be at the bottom of that big pink hunk. So anytime that is compromised, it's going to be really hard for the food to enter the oral cavity and get pushed back. Because as you can see, the esophagus is this little, it looks skinny here in this picture, but it's this skinny little tube, and the trachea is in front. So for that tongue to push the food all the way to the back and to not leave any residue hanging out in these little, you can see there's a label for the epiglottis. That epiglottis, there's a little cavity above it that food likes to get stuck in. So the tongue has to have full mobility, and not only full mobility, but strength to appropriately push the food back and safely to the esophagus. And then again, with liquids, if that tongue is not moving as quickly, especially the speed of the tongue is an issue with the liquids, because to get the liquids back safely, the tongue has to move fast. The swallow in general happens very quickly. So if your muscles are slowed down at all, it's going to make eating and drinking safely an issue. So what can you do about it? If you are having any of those previously mentioned symptoms that I had at the beginning of this swallow section, you need to be getting treatment from a speech therapist, or at least consulting with them, because again, if your swallow is compromised at all, you are at that increased risk for aspiration, and we really don't need to add any other respiratory issues to an already compromised respiratory system. So an SLP can help you determine if there's any diet modifications that can be made. Maybe the food is too dry. I have that issue a lot with patients that I see in the nursing home setting. Their muscles may be just a little bit slower as well due to stroke or Parkinson's disease. Any of those diagnoses kind of have the same effect, can have the same effect, just slowing the muscles down. So, I don't want you to think that a diet modification automatically means you're going to pureed food. There's a lot of in between that can happen that can make you have a safer swallow and a more enjoyable eating experience, truthfully, and hopefully would then keep your intake up and prevent weight loss. And again, an SLP can be very helpful in just teaching safe swallowing precautions. So I'm going to give you a list of those safe swallowing precautions, but again, it's one thing for me to tell you what to do. You really need to be actively seeing an SLP for them to kind of teach you and to show you some maneuvers or strategies that you can use. Anyway, regardless of symptom presentation, I would, for most, maybe I would say all SLP patients, I would highly recommend getting a modified barium swallow study, or some people call it a video fluoroscopy swallow study done. And this is basically just an X-ray, an active video X-ray of what food looks like going down into your esophagus. And if anything, it can just give a baseline of your swallow function, and if everything looks great, good. Now you know, and if you're not silently aspirating, which can happen a lot. And if there are any issues, the speech therapist is much better informed on, okay, well, where is there maybe some reduced range of motion, or if something's just totally immobile, we need to know which muscles are being affected, where the problem is at, so that we can most appropriately give you some strategies that will keep your swallow as safe as possible. So again, these are just some general safe swallowing precautions. I always recommend to all of my swallowing patients that while you are eating and drinking, you should be positioned as fully upright or at a 90-degree angle, as upright as possible. And I know that can be difficult depending on just the areas of the different lesions that different patients can have. But if you can, just try to be as upright as possible, and try to make sure you stay upright 30 to 45 minutes after eating and drinking, which is something that a lot of people kind of don't do. And the reason I suggest that is because if you are having issues getting your food cleared, basically, so if you're having issues getting the food back to your esophagus without any residue hanging out around deep in the throat, if you eat a meal and then you lean back or lay back to take a nap, if there's any residue hanging out, that residue is going to be at a very high risk of getting into the lungs, because you don't have your airway blocked off when you are sleeping, because it needs to be open so you can breathe. So while it's open, it is definitely at risk for residue to fall in and cause that bacterial pneumonia to potentially occur. So again, I always tell people small bites, small sips. If you can imagine the size of a quarter, that's kind of about the size of a bite you should take. And obviously not talking while chewing and swallowing, and going slow. So when I say go slow, I don't mean, you have to chew like a turtle or something, but just making sure that you are not taking another another bite before your initial bite or drink is completely swallowed. And again, you want to just try to take a bite, take a drink, alternate those solids and liquids. Another big area that can be impacted is respiration. So this can be caused because of the thoracic insufficiency syndrome. And that can just result in a progressively reduced chest wall expansion, reduced vital and inspiratory capacity, expiratory flow rate. These can result in complications such as pneumonia, hypoxemia, hypercarbia, retained secretions, pulmonary hypertension, and right-sided heart failure. And additionally, it can impact your vocal volume and your vocal endurance and cough effectiveness. In the FOP guidelines, it stated that chest infection is in the presence of diminished pulmonary reserve is the major life-threatening hazard to patients with FOP. So maintaining this strong respiratory system is crucial. So what can you do about it? Well, definitely be working with a pulmonologist, respiratory therapist, and speech therapist early in diagnosis. And this is definitely as a preventative measure. You want to maintain this function as long as you can. So the goal is to maximize your respiratory muscle function and your ability to clear secretions. So that's basically how well can you cough out any junk that gets into your airway. And of course, you want to prevent or manage respiratory infection by getting the appropriate vaccines as indicated for FOP patients. Again, you want to be practicing and learning how to do abdominal breathing. A lot of FOP patients inevitably will rely on this type of breathing, so it's good to become proficient at it because it's going to make your respiratory system much more efficient. So what can you do about it? So the FOP treatment guidelines recommend 15 to 30 minutes of active respiratory activity per day. It should not cause pain or be uncomfortable, and definitely stop if you're feeling lightheaded. But these activities that you can do at home can just be vigorous, continuous singing. If you like singing in the shower, that would be the activity to do. Or vigorous speaking tasks. Work with your speech therapist to determine what would be appropriate. I am an LSVT Loud certified speech therapist, and a lot of treatment strategies that we use within this protocol, which is actually designed for patients with Parkinson's disease, it's all geared toward loud talking. And so I don't know that I would recommend doing the full protocol for FOP patients just because it is an intensive program, but the idea behind all of the strategies would definitely be something that would be beneficial to a patient with FOP. Again, swimming, hydrotherapy, anything that can encourage those big, deep breaths. So again, deep breathing, there are different tools that you can use that really encourage the deep breathing, such as an incentive spirometer, a peak flow whistle or meter. And I use this last one a lot. It's called the breather. You can get it. All of these products are on Amazon for $40 or less, but I use the breather device a lot with my swallowing patients actually, because the goal of the breather is to improve, you can improve your inspiratory strength or flow rate, and then I use it for the swallowing patients because it can really improve your expiratory flow rate or your expiratory strength. And that is very important for swallowing patients because it helps with your cough strength and your cough sensitivity. So being able to recognize when something goes in the wrong tube, and then obviously having the strength to get it out. I threw yoga in on there as well because, again, anything that can encourage the deep breathing is going to be good to maintain that respiratory health. And again, so maximizing your cough effectiveness is important. You're going to be wanting to work with a respiratory therapist. I know that patients in the past that I've had have used like an a cappella device, so that will loosen the secretions. But it's important to not only get those secretions loosened, but you have to have a way of getting them out. So that's why, again, the use of that breather device is helpful because it's improving your expiratory muscle strength, which can help cough those secretions out. And then any other activities mentioned to improve vocal loudness and endurance can help with the cough effectiveness. So again, voice can also be impacted by this thoracic insufficiency syndrome because it affects your vocal loudness and endurance and can, again, result in reduced speaking intelligibility, how well you're understood, and reduce your ability to just maintain a good, comfortable voice during longer or more intensive vocal activities such as singing, or just some people may just have difficulty with longer sentences, conversations, public speaking. You may find it hard to complete these activities comfortably, or just even some people may even feel short of breath completing these activities because of the effect of the thoracic insufficiency syndrome. So again, you would want to working with a speech therapist to achieve your most comfortable, understandable, and reliable voice. Some things that you may talk to a speech therapist about are doing resonant voice training, and this is just a type of voice that you're really working on that abdominal breathing, and to produce this resonant voice, which will be a stronger, more reliable voice for most people with any issues with chest wall expansion. And then again, trying the modified LSVT loud treatment strategies to improve that vocal loudness and endurance. Now there is the event that, your voice may kind of be past the point of prevention of a reduced speaking loudness. And if that's the case, it may be a good idea to purchase a personal amplification system. There's things out there like the Williamson Pocket Talker that you can get, that they're just these little personal amplification. They're portable. You clip them on your belt. It's like a little microphone for yourself that just makes your voice a little bit louder. And then the last area that can be impacted is cognition, and mainly that is an issue just because of the increased fall risk with FOP, and the upper limbs are usually impacted more, so you don't have as great ability to absorb an impact from a fall, which can, of course, result in more severe head injuries, loss of consciousness, mild traumatic brain injuries, and neck and back injuries. So what can you do about it? Definitely be working with a physical or occupational therapist, learning those fall prevention strategies, and as they spoke about before in the previous presentation, just working with a physical therapist to make sure that you are making any environmental modifications to reduce your fall risk. I know in the home health setting, there's a lot of elderly people that will have a physical therapist or an occupational therapist come out to their home to kind of help set up their home the best way to prevent falls from occurring in the home. And again, you might consider regular helmet use for small children to just prevent those severe head injuries, as all children are accident prone, and if their balance or limb mobility is impacted at all, they're at even greater risk for a head injury. And I just really want to emphasize that any head or neck injury should be considered serious until proven otherwise. So it is important that your doctors are okay with liberal use of head CTs or MRIs to rule out subdural hematomas or any other brain injury that could be occurring kind of under the surface. It's important to know the symptoms of brain injury, and these often don't happen until hours, sometimes days after the physical injury. So it's important to notify your doctor if you are experiencing headache, dizziness, drowsiness, reduced level of consciousness or sensitivity to light, weakness, confusion, or total loss of consciousness. And again, if you have had a head injury or recently or even years ago, I would recommend seeking out a speech therapist to just determine if cognition was affected. So when I say cognition, I mean like your memory and attention, ability to organize your thoughts, those kinds of things. You definitely would want to seek out a speech therapist for an evaluation, and then if there is a cognitive deficit present, you would want to see which strategies they would recommend to help remediate that. I believe that is all. Sorry, I was kind of going fast there at the end. Back to you, Hope.
Thank you, Veronica, for doing such thorough homework to learn more about the FOP community and for being so thorough in your presentation. I know that speech language pathology is something that is relatively new, so I'm excited that our community was able to learn so much about it in this presentation. Our next panelist is Kelle Oestreich. Kelle spent the majority of her career at the bedside caring for adult critical care patients. Her expertise also include disease management, specifically educating high-risk patients with asthma and COPD. Kelle is an associate professor of respiratory care at Johnson County Community College in Overland Park, Kansas. Over to you, Kelle.
Hi, I'm so happy to be here with all of you today, even if it is virtually. I'm going to be talking about lung health and FOP. And today I'm going to help you understand what it means to have healthy lungs and how to keep your lungs healthy. I'll be describing some breathing techniques and exercises to maintain lung health in FOP. Life begins with a big first breath in, and a human lifetime, you might say, is measured from the first to the last breath. The process depends on how we breathe. Breathing is an instinctive reflex to satisfy our body's need for oxygen, but it has been reasoned that consciously controlled breathing can be used as a technique for enhancing mental and physical health. Most of us breathe without even thinking about it. Today, I'd like to spend a few minutes thinking about how we breathe and how we might keep our lungs healthy and improve lung health. To better understand your lungs, I want you to think of a tree, and there is an upside-down tree in each of us. Your windpipe is like the trunk of a tree, and from the trunk, the airways divide like branches of a tree. At the end of a tree's branches are leaves. Similarly, the ends of our smallest airways have tiny air sacs where carbon dioxide is exchanged for oxygen. Healthy lungs are free of secretions, able to inhale deeply, and produce a strong cough. We also have a muscle of breathing called the diaphragm. It's a thin muscle. It separates the chest and abdominal cavities. It'll tighten and pull down as we breathe in, opening the chest cavity and allowing the lungs to expand. To breathe out, your diaphragm relaxes and moves upwards, pushing air out. In FOP, the chest cavity is often restricted, and this restriction may make it difficult for the lungs to expand fully. Somewhere along the way from childhood to adulthood, most of us subconsciously have changed the way that we breathe. As babies and children, we naturally breathe deeper. Have you ever noticed how a baby's belly will rise and fall as they breathe in and out? Yet as adults, it's our chest that rises and falls when we breathe. Now, why does this matter? Well, deep breaths are more efficient. They allow our bodies to exchange incoming oxygen with outgoing carbon dioxide. They've also been shown to slow the heartbeat, lower or stabilize blood pressure, and lower stress. Repeated deep breaths will naturally bring your heart rate more in sync with your breath. And this leads your brain to release endorphins, which are chemicals that have a natural calming effect. And 2020 has been kind of a rough year on all of us, and I think we can all use some calming. So I thought before I really get into lung expansion exercises for FOP, I'd like us to take a moment to practice some deep breathing, and I will guide you through this. So I'd like you to sit upright, place your hands on your belly, go ahead and close your eyes, and I want you to inhale. Try to make your hands move away from your body if you can as you inhale, because that'll mean that you're taking those deep breaths using your belly. So close your eyes, inhale slowly and deeply through your nose. Hold it for 1, 2, 3, and exhale normally. Let's do it again. Deep breath in. Hold it for 1, 2, 3, exhale. And one more time. Big breath in through your nose. And exhale through your mouth. So hopefully you feel a little more relaxed. Taking a few deep breaths for a moment is not going to improve your lung capacity, but it's an easy way to reduce stress and relax. Now, because of the restriction that FOP causes to the movement of the chest wall, a daily routine of practicing lung expansion is highly encouraged. With restrictive lung conditions, there's a tendency to take small, shallow breaths. And over time, shallow breathing can lead to areas of the lung that become airless. And these airless regions of the lungs no longer participate in the exchange of carbon dioxide for oxygen. An incentive spirometer is used to help keep lungs healthy and improve lung health. They're designed to help you take long, deep breaths, such as when you yawn. The incentive spirometer shows you how well you're taking a deep breath and keeping your lungs expanded. Because it makes you breathe deeply, it improves your ability to clear mucus from your lungs. It may also increase the amount of oxygen that gets deep into your lungs. So I'm going to show you how to perform an incentive spirometer, and it's simple to use, but there is a right and a wrong way, and so I'm going to show you how to use one the correct way. Now, I have seen patients try to blow through this, and that is incorrect. We want to breathe in. We want to expand our lungs. And there's a piston that will actually move up as you breathe in, and this is showing you how big of a breath you're taking. That's really not important, okay? That's not as important as there's a visual indicator. I'm going to hold it up to the web camera, and hopefully that you can see mine. There's a visual indicator here. Mine has a happy face. So as I'm taking a deep breath in, I'm going to move this yellow tab up into the happy face, and that's telling me that I'm taking a slow, effective big breath in. That's what we want. We don't want to see any frowny faces. And you'll really, as you do this on a daily basis, your best effort will become your goal. If you want a specific number for your goal, then you'd have to talk with your physician, and some pulmonary function studies could be ordered to determine a goal for you, but your best effort should really be your goal. So I'm going to sit upright in a chair. You should always be sitting upright as tall as you can. And you'll just exhale normally, place it in your mouth, and inhale slowly and deeply. And then after you've inhaled slowly and deeply, I want you to hold that for a count of at least 3, and then just breathe out normally. Okay, so here I go. Just one more time. All right, now this should be done, at least 10 times in a row. A good time, have it handy where you're going to see it and remind yourself to use one. And during commercial breaks, perhaps during your favorite television show would be a great time to do that. Spend at least twice a day doing it 10 times in a row. If you notice you're getting dizzy or lightheaded when you're doing this, then you need to slow down and take a break, okay, because you're going too fast. Now, children sometimes have a hard time following instructions and doing the incentive spirometer, and that's just fine, because there's other things that we can do for kids. We can get creative. So singing is excellent. I know that that was mentioned before. If they could join a choir or encourage singing around the house, get perhaps karaoke machine, spend some time singing to the radio, but make it fun. And I'm a horrific singer, so I'm not going to demonstrate this skill for you, but I think you get the idea. But to sing, in order to sing, you have to take big, deep breaths in. Then we also have swimming. This is an excellent low-impact exercise for FOP patients, and it also happens to be really fun. Now, can you guess why that this is good for your lung health? Because to go underwater, you have to take a deep breath in and hold it, and that's essentially lung expansion therapy, taking a big breath in and holding it. And make it fun. So the kazoo or the harmonica, these are fun activities, maybe not for parents having to listen to it all the time. But, as they get better and can play some songs, it'll be okay. So be supportive of music in your home. And as the child is breathing out through the kazoo or the harmonica to produce sound, they're actually creating lung expansion, because that blowing out against the harmonica and the kazoo is actually giving them some positive end expiratory pressure, resistance, and that resistance travels down into those airways, and it'll pop open those air sacs, which is great for lung expansion and gas exchange. And then if you want some quieter lung expansion activities, blowing a pinwheel, children enjoy. And do you remember, make a wish, go outside, find some dandelions and have them make a wish and blow. And blowing bubbles is always fun. These are great lung expansion activities for children. And then the last one that I found, I thought this was such a creative idea. You just drop some paint on paper or canvas and then give the child a straw and have them blow the paint around and see what kind of creatures they can create. You could put some googly eyes on here or draw some scales and make a fish. Just have fun with it. So just to review, healthy lungs are free of retained secretions. They're able to inhale deeply and produce a strong cough. Because of the chest restriction FOP causes to the movement of the chest wall, a daily routine of practicing lung expansion is highly encouraged, 15 to 30 minutes per day. It doesn't have to be done in a 30-minute chunk all at one time, but that should be the goal, 15 to 30 minutes every day. So try to make the conscious decision every day to do something for yourself and to keep your lungs healthy. All right, so thank you. I'll give it back to Hope now.
Thank you so much, Kelle, for sharing that important information about a topic that is so critical for our FOP community. So now we'll welcome all of the panelists into the video. And we did have just a few questions that came in during the presentation. So Dr. Baujat, the first one is for you. Is there a method for measuring range of movement? And this is for a child who's 3.5 years old by a physiotherapist or an occupational therapist?
So there are two ways. Can you hear me? Is it okay?
Yes, I can hear you. Mm-hmm.
Okay, so there are two ways to measure it. At first, the goniometry using a goniometer, and it is something usually done performed by physiotherapists, but also by orthopedics or physician in physical therapy, and you can measure the precise joint mobility. And as you know, probably more and more we use something useful for the trials, the new drugs trials, which is a KGIS, which is a score, very simple one, and you measure for all the joints simply. If it is normal, it is a score of 0. If it's less than 10%, it is 2, and between it is 1. And this is a very useful way to measure the joint mobility. And what we do in our place is to combine both KGs with simple goniometry to see how things goes prospectively. So yes, we have two ways to measure, and it is really useful for everybody.
And was one of those the Hammersmith? Are you familiar with that method?
Alors, I'm not a physiotherapist. I'm not familiar with, but probably it is something used by physiotherapists. Okay. I just know the name.
Yeah. Thank you, Dr. Baujat. Veronica, there are two questions for you. So the first is, have you noticed tongue tie increases the prevalence of submandibular flares? If you have worked with any other patients who've had those?
I have not worked with any patients personally, just because FOP is so rare, and I have not encountered submandibular flares myself for other causes. I can only speak to my knowledge of tongue tie and how that can impact the muscles. So actually, tongue tie, unless it's a severe tongue tie, it really shouldn't be having much of an effect on the tongue muscle itself. And so I can only imagine that if the tongue tie were severe and it were making the tongue work really hard or causing basically stress to the muscle because of what the muscle has to do to overcome the tongue tie, I would imagine that would maybe be the only way that tongue tie could result in a flare-up of in the submandibular region. But otherwise, most tongue ties really don't impact the speech or the tongue muscles that much. It actually is more, it affects infants more than anything with their feeding than actually speaking itself. So again, I wouldn't imagine it would have an increased likelihood of flare-up unless it was like a really severe tongue tie.
Okay, so, thank you. That was one of our FOP dental experts. One of our FOP dental experts had asked that question. So I know he's probably very curious about how that's impacted. So I will give attendees, if there's any last questions that people would like to submit. Let's see. Oh, there's one that came in that said that PFO can in some cases result in poor swallowing and hair loss. Is there any medical recommendation known to date? So the PFO, I'm not sure what that FOP. Oh, that is, I'm sorry. That FOP can in some cases result in poor swallowing and hair loss. So if there's any medical recommendation known to date, I think that Veronica has pointed out some really helpful resources and tools to improve swallowing and recommendations to contact a speech language therapist for those needs. So I would definitely say that yes, there are recommendations to follow up with a speech language pathologist for those needs, for poor swallowing. Okay. Well, I do not have any other questions in the Q&A or the chat at this time. So, and we are coming up right at the end of our session. So I want to again thank our panelists for joining us today. And it's wonderful to expand our knowledge as an FOP community by bringing in these different subject matter experts. So thank you for kind of launching us down this new road. And to all of our attendees, I just wanted to give you a preview of what is to come. So there is a little comfort break taking place right now. And if you are the mother of a pediatric participant or a kiddo at this event, there is going to be a kids contest taking place on Zoom. You can find the link to that in the agenda in the theater. And there will be some small group discussions facilitated by members of the FOP community or IFOPA staff that will be starting at 2:30 Eastern Time and 19:30 GMT. And we'll have some exhibit hall time. And then tonight, don't miss the Share Your Strength talent show. We've had some great videos submitted by community members doing and showcasing their different talents. So we will be sharing those at 7 p.m. Eastern Time, 2300 GMT in the link in the agenda. And there's also a photo booth that you can go to our lounge and share photos from you participating at home in the event or whatever it is you'd like to share with the community. So I hope you'll take full advantage of these opportunities to come together as an FOP community in our second day of the event. So thank you, everyone, and enjoy the rest of your day.